he says that he is having restriction of movements. Will you directly go to MRI? Will you straight away jump to the MRI, or some will say that I'll do X-ray, and X-ray comes normal. So my talk is on that only, that how can we diagnose various shoulder problems based on the clinical examination only. So patient comes, you ask his history, ask his name, age, what kind of work he do, and any history of trauma, and since how long he is having these symptoms. Is he having any comorbidities like diabetes or hypertension? Most importantly, ask him that if he is having chronic illness, did he had intraarticular steroid injections previously? If he says yes, the diagnosis can change completely, or our management can change completely. We do clinical history, we ask about the pain, how it is characterized, where it is located, does he having night pain more, or it is continuous throughout the day, does he also having any weakness, some deformity, is he complaining about any instability like during throwing some object, does he feel some clicking or locking of his shoulder joint, does he play sports or previous treatment as I told, and aggravating and relieving factor for the pain, is it acute, chronic, any overuse of the shoulder. So we do physical examination, we do like journal inspection, palpation, we check for the range of motion, and there are some special tests for that. First of all, we check in the inspection, we check from the front and back of the shoulder, we check for the height and the level of the scapula, we check for any asymmetry, we check for any obvious deformity which is seen, any ecchymosis for the trauma, and we can also check for any muscle atrophy for supraspinatus, deltoid or infraspinatus. Then we go for the palpation. We see at the rest and the movement, we check for the temperature of the joint, that is it normal as compared to the opposite side, or is it normal. We check the bony structures, joints and the soft tissues around the shoulder. In the anterior part, we check for the clavicle, SC joint, acromion process, AC joint, deltoid, coracoid process, pectoralis major, trapezius and biceps. In the posterior aspect, we check for the scapular spine, acromion process, supraspinatus, infra, deltoid, trapezius and latissimus dorsi. Then we check for the range of motion. Normal person can flex his shoulder up to 180 degree, extend it up to 60 degree, abduction is up to 180 degree, adduction is up to 45 degree, internal and external rotation is up to 60 to 90 degree. Apley scratch test, it comprises of all the motion. We ask the patient to touch the back of the scapula. The level where he can touch, we can determine that how much muscle is his body is acting. Then we check the strength of each muscle by the normal grading system, 0 for no contraction and 5 for the normal power. Once we are done with all this, then we have this dilemma that whether it is an impingement syndrome, or is it a frozen shoulder, or is it a rotator cuff tear, or is it instability. For these various special tests are mentioned, and I'll show you demonstration of each test. On subacromial, first of all, we check for the impingement syndrome. It can be impingement of subacromial bursa, rotator cuff muscles, tendons or biceps tendon, and these got impinged between the acromion, coracoacromial ligament, AC joint, coracoid process or humerus head. So first of all, we check for the impingement. In this, there is a test called Neer's test, in which when the arm is fully pronated and placed in force flexion, we try to impinge the subacromial structure with the humeral head, and it produces the pain. So it is positive when patient complains of pain. That means patient is having impingement. To confirm it, we can do Hawkins test for internal and external rotation, where arm is forward elevated to 90 degrees, then forcibly internally rotated and trying to impinge the subacromial structure with the humerus head, and when there is pain, it is positive test. Then we check for the instability. There is load shift, anterior and posterior, we stabilize the scapula with one hand, and with other we hold the humerus and we try to push and pull it back. If it is getting subluxated, that means there is instability of the shoulder. We check for the anterior apprehension test, in which anterior instability we check at the shoulder is abducted to 90°. Slight stress to the humerus head is directed in the anterior direction while externally rotating the shoulder. And positive test is apprehension. Patient develops the feeling that his shoulder is getting dislocated. In the posterior apprehension test, patient is lying supine. We flex the elbow. We stabilize the scapula with one hand and arm with the other, and we try to push the humerus head downwards. Like in this, it is showing some grade of instability. In the multi-directional instability, what we do, it is for the inferior instability, arm is relaxed in the neutral position and arm is pulled downward at the wrist. And the positive test is a visible sulcus. You see a depression in at the deltoid level, and the acromion and the infraacromial area, you see a sulcus. So this is a sulcus test. Next is Obrand test. It is for the labral AC joint or biceps pathology, where the arm is flexed to 90°, arm is cross adducted to 15°, and then elbow is extended, and with the maximum pronation, when we try to push it down, patient develop pain, and then we ask the patient to move externally rotate his arm, and then we try to push the arm, and if he is complaining of pain, that means there is a labral tear. Then for the biceps tendinopathies, what we do is forward flex the shoulder to about 90°, then adduct the shoulder to about 10° with the arm in full supination, and then we ask the patient to apply the pressure, and we give the resistance, and patient start developing pain at the distal arm. Second is Jergerson test, in which same elbow is flexed and forearm is in pronation. In earlier test, speed test, it was in supination, now it is in pronation, and then we have to check against the resistance. If patients started complaining of pain, it can be tendinosis or subluxation of biceps tendon. Now for the rotator cuff pathology, first is supraspinatus. There is a drop arm test in which we abduct the arm slowly and it is lowered, but whenever we reach a level and we ask the patient to stabilize the arm at that level, if there is a tear, the arm will fall directly to his sides. In the Job's empty can sign, in this position, both arms are placed approximately 90° of abduction with scapular plane with maximal internal rotation. That means thumb should be downwards. The patient then attempts to forward abduct the humerus against the resistance of the examiner, and it produces the pain. For subscapularis, there are two tests. First is the belly press test, in which the patient try to, with his arm, with his hand, try to press his belly, and you can see a line. If we draw a straight line from the shoulder, the elbow should cross that line. If he is crossing that line, that means his shoulder, his subscapularis is normal. In the Liftoff test, we ask the patient to lift his arm in the full external rotation. He try to lift his arm and we give a resistance. If he is able to touch his back again, that means his subscapularis muscles are weak. For infraspinatus, we do external rotation against resistance, and same we can check for subscapularis internal rotation against resistance. Then for AC joint, we do cross arm adduction test. We flex the arm to 90°, and then up to adduction is done up to 45°, and we ask the patient to touch his opposite shoulder. If he is able to do, then it's okay. Then we try to push his elbow downwards, and if that produces the pain, that means the AC joint is either degenerated or it is tear at the AC joint. And the last, which is most common, is adhesive capsulitis. How can we diagnose adhesive capsulitis clinically? In this, the patient will complain of all other pathologies. We can do active range of motions. But in adhesive capsulitis, we can't even lift patient's hand by applying pressure by ourselves. Means active movement is also very painful in this, and rotations are also painful. So in adhesive capsulitis, main complaint is always pain. In all other, there is either instability or range of motion is restricted, but in adhesive capsulitis, it is always the pain, and that too, active range of motion is not possible in this. So this is my small talk on the clinical examination of shoulder. Thank you.